I'm the project manager for the California Improvement Network. Today's webinar is entitled Matching Patient Expectations with Patient Experience. And we will hear from Dr. David Newhouse of Kaiser Permanente's Data, Diversity, and Demographics program on how the program uses data to address unconscious biases and healthcare disparities. Just a couple of housekeeping items before we begin. This session will be recorded. We'll be posting the slides and the recording on the CIN website in about a week. And if folks could please just turn off phones and ringers and pagers, etc., and any hold music. We will be muting everyone, but just in case we take folks off of mute for the Q&A, that would be appreciated. For questions, if anyone has any questions during today's sessions, you can use the chat function to ask them. If it's a logistical question, just send it to the host. If it's a question for the speaker, you can send it to the, if you send it to all the participants, then everyone can see what questions are being asked, and so we can make sure we address everything and there aren't too many repeats. And today's speaker, as I mentioned, is going to be Dr. David Newhouse. David is an assistant physician-in-chief for the Fremont Hayward facilities, which are part of the Kaiser Permanente Medical Group located in Northern California. His time is spent half clinical as an OBGYN and half administrative. The administrative roles include diversity, marketing, leadership development, performance improvement, and being the medical director for the IVF Center in Fremont. After receiving his medical degree from Michigan State University in 1974, the next 4 years were spent at the Gorgas Hospital in the Panama Canal Zone doing his internship and residency programs. He left the Canal Zone in 1978 and received his master's degree in public health from Berkeley in 1979 before joining the Permanente Medical Group. His current work is focused on the issues of diversity and its impact on patient care. The demographics of patients, staff, and physicians are rapidly changing and adding to the challenges of providing health care in the U.S. Current projects include analytics to help identify potential unconscious bias in the physician-patient encounter and healthcare inequities such as gaps in hypertension control between whites and people of color. Another key area of interest is developing a leadership training program that takes into account gender, race, ethnicity, and generational issues. So with that, we'll hand it over to Dr. Newhouse to begin the presentation. And
okay, great. Well, thank you, and good afternoon, everybody, and thank you for tuning in for this program. Go to the next slide here. I think the first thing I want to talk about is, what do I see as kind of a key issue that's happening around the state and, of course, around the country, is that when I joined Kaiser Permanente in 1979, the facility I was at was 92% white. It's now 42% white, and we're losing about 1% of our white patient population a year. In our pediatric department, only 15% of the children seen here are white. And so I think the challenge is becoming is, how do we manage issues around service, quality outcomes? How do you manage a diverse workforce? And I think that what is becoming clear to me is that we really have to start collecting databases if we're going to decrease disparities in healthcare. And also, there's the issue that I'm finding is that as our staff and patients become more diverse, is that we're finding that pay-for-performance metrics can sometimes not be fairly applied, particularly against organizations and physicians with large, diverse populations. So what I'm going to talk about a little bit today is our service score program and how we use analytics. I'm going to give you an example of the demographic variation impact on pay for performance, and then I'll give you some sample cases about how we look at physician scores. And then the last topic I'll talk about briefly is the interest I have in the issue of unconscious bias. So that's kind of the objectives for the hour. So analytics. I don't know how many of you are baseball fans, but if you saw the movie Moneyball, which is a true story about the Oakland Athletics, they actually use analytics. And what they were doing was they were using statistics to actually identify potential baseball players who were actually good baseball players, but because of bias on how they looked as a baseball player, were sort of unrecognized by other teams. And so using statistics, they were actually able to put together a team that almost went all the way to the World Series. Because what they found is that when baseball scouts would look at baseball players, they would look to see, does this look like a baseball player? Does he look like he has speed or power? And if he looked like this pitcher here, you see who threw underarm, he didn't look like a pitcher. So they were able to pick up a pitcher that if he threw normally, like most pitchers do, probably make $3 million a year, they're able to pick him up for a couple $100,000. So that's one of the concepts I want to talk about is I think as we start to look at disparities and unconscious bias, that I think analytics is going to be one of the ways we can help find out what's really going on. So a little bit about our member survey. Here in Northern California, we have about 1.5 million surveys returned every year. And every physician in Northern California receives about an average of 100 surveys per year. And based on that, you can see on this slide here, this would be an example of something of an overall score of around 90%. And so what we're finding is that pretty much we just looked at the overall score to kind of determine how well somebody was doing. So if they were a 90% scoring doctor on a 100-point scale, you were considered a good doctor. And if you were scoring, say, 60% satisfaction, you'd be considered a poor scoring doctor. Well, that's what we've been doing pretty much since 1992 when we started doing this. And what I found is that when you started looking at different categories, we actually found there was a lot of variation. And the paradox is that when you really focus on the overall score, is that you could actually start missing out on key demographic groups. And I'll give you an example here with the next slide. So this was an example of a male internal medicine doctor who had been with us for many years. And this was his score. This is an earlier slide, so it was only 2 years of scores, but when I looked at it later, it was the same pattern. When this doctor saw patients that were over the age of 45, pretty much year after year, this doctor was scoring in the high 80s or low 90s. When this doctor saw patients under 34, the doctor was scoring only in the 40% range, again, year after year. Well, why is this an important demographic group? Because for any healthcare organization, you certainly want to be able to hang on to your young members, because these represent the future. And when I asked this doctor about, well, why don't you score higher with these patients, his reaction was, well, I don't even want to see them, they're not even sick. So here was a doctor who, based on his biases, did not care to see young adults, and it showed up in his scores. And so this is the kind of thing that we're looking for is most doctors do well with most of their patient groups, but when you break out their scores into subsets, you can start to see certain patterns where there could be room for improvement. So how did this all start? Now, as you heard, I'm an OBGYN doctor, and this is actually a cover from Medical Economics from the year 2002, and of course it says our male OBGYNs headed for extinction. When I joined the OBGYN department here in 1979, there were no women in the department. I'm now the only man left. And this is the pattern we're seeing across the country, is that in OBGYN now, women have come into the specialty. There's a lot of push where people want to see somebody of the same gender, perhaps the same race or ethnicity, same language concordance. So what I was finding was, and I'll go to my next slide here, when I looked at my scores in 2003, my scores were starting to drift down. And this is a copy of my actual MPS scores, which we call page 2. The first page would have had my overall score. The second page had my scores broken out in some basic categories. Familiarity, which is, have you seen Dr. Smith before, yes or no, patient age, and then race and ethnicity. So in 2003, my scores were drifting down, and I couldn't figure out what was going on. And so when I looked at my scores by age, in the middle column there, you can see that when I saw patients over the age of 45, I was again scoring consistently above the 80s or 90s. When I saw somebody under 34, I was scoring around 35%. And this is how it would go. I'd walk into the room, hi, I'm Dr. Newhouse, nice to meet you. I don't want to see you, you're a man. well, then hell, I don't want to see you either. So you can imagine that's why the scores were so low, because neither person was happy seeing the other. So I thought about it, and I thought, you know what, I have to get past my own biases. And so what I decided to do was, first of all, I had my MA, my medical assistant would do a pre-session with the patient, talk about, do what we call the build-up, say, you'll like seeing Dr. Newhouse, et cetera. And then I would go in and do everything I could to make that the best possible visit, answer every question, spend extra time, the whole idea being to build trust. So the next time I got my scores 3 months later, that score went from 35 to 96. And even though it was only 10% of my overall patient visit population, it had such an improvement in that category that it raised my overall score up 12 points. So that's when I got the idea of this was something that worked for me in that I didn't have to fix my service scores with everybody. I just had to find the key area where I had a gap and work on that. So that's when I started taking it to the medicine department here in my own facility. And from there, the Fremont Medicine Department became a significant improving department. And from that, this is now spread over most of the facilities in Northern California. So this is what we did. We took the data that we had and we broke it down into a new format. The idea being is that we wanted to be able to give the doctors a really good breakdown of their scores. So what you have there, if you take the top two columns there, you see familiar visit and stranger visit. You'll see that you have 3 years of scores, 2007, 8, and 9. You see the 3-year average of those scores. We then compare that with the 3-year average for that physician's department scores. So if that physician is in medicine, they would be compared with the medicine department. If they're in pediatrics, they would be compared with their own pediatric department. The next column shows the difference. And then we color-coded it. If it was plus or minus 5 points within the department average, it's in white. If it's 5 to 10 points negative, it's in orange. If it's more than 10 points negative, it's in red. If it's more than 5 to 10 points positive, it's blue. And at more than 10 points positive, it's green. And on the next side of the page, which you can't see on this slide, but is there, is that for each of the 3 years, you would have the number of surveys in every category, so that would give you an idea of what's the ratio of what you have. So are you seeing a large white population, a large Chinese population? The number of surveys would be able to give you that kind of information. And so what we have there is we have your familiarity, your basic categories of age, race and ethnicity, and gender. The next key thing is when I started working with doctors is doctors tend to look at these numbers as being very literal. And sometimes they would question, well, why is there a 1 or 2 point difference? And what I really think is that when you start to look at this type of format, is what you're really looking is patterns. You know, what is the pattern that's going on here? Not get caught up on 2 or 3 point changes one way or another. It's really how to take a look at your data and start to break it down to see what's consistent. So I'll give you an example here. Here in Fremont, we have a very large Indian population. And because we have a very diverse population here in Fremont, we've been doing a number of focus groups. We also have the largest Afghan population in the state, a large refugee population. So we also have a very large Filipino, Latino, Vietnamese, and also a deaf school here. But we did 5 focus groups, and one of them was with the Indian population. And it was very interesting that one of the key things that came out of that focus group was that when we asked the patients from India which doctor they didn't like to see, it turned out to be the 2nd-generation Indian doctors. And here's an example of a young 2nd-generation Indian physician, and you can see that when you look at the scores for other Asian, that's the score that falls out as being the lowest. And again, this was a doctor who liked seeing everybody but Indian patients. In her own words, she says, they drive me crazy. Well, if you don't like seeing a certain group, you're probably going to have a real problem having high scores with that group. She did very well with Latino, white patients, Filipino, and Chinese. One of the things that's important to understand about the data too is that one of the things I was finding is that there can be unintended consequences of pay for performance. And so that's why it was not just understanding the scores, but also understanding the trends and the ratios. Because what we really want to do is when we start to evaluate our physicians is we really want to make sure that we're recognizing what they really do. And also I found that if you put enough pressure on doctors, they'll start gaming the system. And there's ways of actually gaming the system so you can, create problems for not getting true accuracy on what they're really doing in the clinic. So I'm going to show you an example here of why it's so important to understand ratios. And by the way, that's me down there in the left lower column there, picture there. What I took here is I took our service scores for the medicine departments, all the medicine departments for Northern California. This was about 500,000 surveys a year. So what I'm going to do is I'm going to create a hypothetical case here. I'm going to have two physicians, and I'm going to give them exactly the same scores for two groups of patients. Familiar Chinese, these are Chinese patients who check they've seen their doctor before. Familiar white, stranger Chinese scores, and then stranger white scores. And again, the stranger visit is one who identifies that they have not seen this doctor before. Now I'm going to take this doctor here, the young Asian female, and I'm going to give her the typical ratio of patients she's probably going to see in the first year or two. So being brand new, she's going to see mostly new patients, and she'll probably have around a 20% familiar return rate, which is typical for the first year. Being Chinese and Mandarin speaking, she'll probably have running roughly around a 70% Chinese ratio and say 30% white. The established physician will have mostly returns and mostly white. So again, they have the same scores, but they have different ratios. So how does the white male doctor score come out? His score is going to come out at 80%. Her score, 63.9%. Now, who's going to get the pay raises? Who's going to get bonuses? Who's going to be recognized as a top-performing physician? The other interesting thing is that when we break these scores out by gender, the gap gets even further apart, because in our medicine department, the women patients scored 3 to 6 points lower than the men did in every race and ethnic category. Now, this is not true in every department. We found that in psychiatry, for example, the women patients tend to score higher than the men. So why is that important? This is an actual case that happened at our facility. In the year 2006, we were told that we were supposed to be hiring only good physicians. And this was a young Mandarin-speaking physician who was up for partnership, and our partnership comes up at about 3 years. And her service scores were barely breaking 60% satisfaction. So the physician-in-chief told the chief that we were not going to hire any doctors with low service scores. Well, this is a real issue, because this was a doctor that everybody liked, had good clinical skills. We also were 12%. We also were not retaining our Chinese-speaking patients. So how did we make the case that this was actually a very good doctor? Well, when I looked at her return rate of patients, and that was the red line with the green triangles, you can see that the return visits were actually going up quite rapidly. So based on that, she made partner. This doctor is now a very highly valued member of our medicine department. She scores consistently in the 80s. And the reason her score was low was for a couple of reasons. Number one is that we turned out that the survey, which went out in Chinese, was not translated correctly. There's no word for excellent in Chinese. And the only thing the doctors get credit for on their scores is either very good or excellent. And we also found out some other things. We did a Chinese focus group, and we found out that patients from China often would stop in without making an appointment in their own country, and so they did that here, and they would bring family members in and expect them to be seen as well. We also found out that our Chinese physicians were actually doing double work, because they had to do it in English as well as Chinese. They did not have a medical assistant who was bilingual in Chinese to do callbacks for them. So in reality, we actually had a group of physicians here who are bilingual, who are doing a lot more work than their white counterparts, and yet we're not getting recognized because they had a low service score. But once we started to understand the issues around the service scores and the fact that the survey was not translated correctly, that culturally often Asian patients will mark lower, then we began to understand that we really needed to compare our Chinese-speaking physicians with other Chinese-speaking physicians. Even at our facility ranking, you know, we are a large organization and there's a lot of competition to see who can have the highest service scores in the region. And the percentage of white patients across Northern California can range as low as 42% at my own facility to as high as 86% up in Marin County. And so this, you can see by the yellow line that what you had the non-adjusted service scores by facility that you had wide fluctuations. But when I gave everybody the same ratio for whites and Latinos and Asian, you see that the red line really flattens out. And while there was some variation, that by adjusting for the ratios, it took away a lot of the wide swings that you see in the service scores by facilities. So I'm going to get into some sample cases here. So this was an example of an Indian female OBGYN doctor, and this is just the component on race and ethnicity. And you can see that, and this happened here in Fremont, that her African American scores were actually about 14 points below the department average. Her Chinese scores were about 13 points below. Her Filipino patients were about 8% low, and Latino scores were about 7 points low. If you looked at other Asian, which in our area tends to be our Indian patients, she actually did above the department average, and she did about 7 points lower than the department average with whites. So for this doctor to actually improve her score, she was doing fine with the Indian population, but what she really needed to work on most was the white population. And why the white population and not the African American? While you certainly would want her to work on the African American population, it only represents about 3% of our population here in Fremont. But if you looked at her white scores, even though it was a higher score, that represented 106 visits out of her total, which for her was the largest group. So one of the things we want the doctors to do is we want to have them give good care to everybody, but we also want them to get their scores up. And so what we look for is what area could they start with that'll give us, excuse me, give them the biggest bang for the buck to start moving their scores up. And then the other two large groups were Latino and Filipino patients. This was another example of a doctor who, this happened recently, where we were going to give out recognition for doctors who scored over 90%. And you can see just at a quick glance at looking at all the green and blue boxes here, this is a very highly performing physician. Yet, because this physician had a higher number of stranger visits, which tend to mark lower than return visits, she would have missed the recognition by less than a point. And this is why it's important to really start to understand your numbers. I mean, what do they really mean? Who truly is a high-performing doctor and who isn't? And when you start to break down these scores into subsets, you start to get a much clearer picture of what's really going on rather than looking at an overall score. And here's a doctor who's just the opposite. This was a doctor that didn't really like seeing anybody. And again, at a quick glance, you can see very quickly that this is a physician who probably should be looking for some other line of work. This doctor did not do well with anybody. Now, I'd like to say that when I first came out with this program, that all the physicians, I thought the physicians would be quite excited about the program, but that was not to be the case. It was amazing to me how much pushback I had from physicians about this kind of a program and looking at data. And one of the things I found is that physicians are very sensitive about their scores. I mean, they all went to college and high school probably as A students, and when you suddenly are told you're a D or a C performer, people get very upset by it. So but in that, given that, I found out I had some real pushback. And one of the comments, for example, and I think probably anybody who's done diversity work has heard this, I heard this from doctors, well, I treat everybody the same. Well, the nice thing about giving them their breakout scores is you're able to look at the data and say, well, if you treat everybody the same, why aren't the scores all high? So you use the data to actually get through their arguments. Why can't they learn to speak English? Again, these are the kinds of things, the pushback you'll get. And given the increasing number of non-English speaking patients that we have in this state, it becomes more and more important that we can't have biases like this, that we're going to have to learn how to treat everybody and get appropriately. Here's another one I had, analysis paralysis. Some doctors just don't want to be burdened with a lot of numbers. So when I work with these physicians on those scores, every doctor that I work with gets a 1-hour private consultation about their service scores. And oftentimes for the first 20 minutes or so, it may be just dealing with anger management because they've been told they were underperforming physician. And rarely you do get somebody like that one doctor that was all red, where it's just somebody that probably is not a good fit in healthcare. But for the most part, I'm able to go through and show them their scores and show them, first thing I show them is all the areas they do well with. And then you start to go through and say, where are the gaps that you can improve? So why is that in score, for example, Latino patients lower than the other groups? What do you think is going on here? And what it really starts to do is it really starts to get the doctor to start thinking about what could be happening with that encounter. And so that way we get past the analysis paralysis. You really get people to learn how to look at their data, focus on it, and come up with an idea of targeting a specific group. Because it's much easier to fix a smaller group than it is to try to fix an overall number. I'm going to talk a little bit about unconscious bias. I don't know how many of you saw these newspaper pictures that went out after Katrina hit New Orleans. But if you look at the top picture there, and you can read the caption, it says, a young man walks through chest-deep floodwater after looting a grocery store in New Orleans on Tuesday, August 30th. Then you read the caption for the two white people down below. It says, 2 residents wade through chest-deep water after finding bread and soda. So the man on top is stealing, and the 2 below are surviving. And this is how you create stereotypes, and this is one of the reasons we have unconscious bias in this country. So what I have found is that one of the key elements in looking at the service scores is that where we tend to find unconscious bias really tends to happen mostly likely in the first visit. Because when 2 people meet for the first time, the doctor and the patient, what do they see? They see skin color, they see gender, they see age, they see what you're wearing, do you have a tattoo? Based on these things, we all make assumptions about each other that are generally wrong. As physicians and patients have repeat visits and trust is built, the unconscious biases, if they're there, go away because now you have trust. And so what I'm finding is that when you look at our service scores, what I look at first is what groups do they do well with on the first visit. So here's this happens to be an emergency room doctor, and basically all visits are first encounters. So here was a white male ED doctor, and you can see that when this doctor saw the white patient population, the doctor scored pretty high, just basically within the range of the department average. When this doctor saw African American and Chinese and Latino, the patient's scores were much lower and a little bit more inconsistent with the Filipino patients over the 3 years. So my advice for this physician is that anybody of color, this is where the doctor had to spend more time to see what was going on. I gave this doctor materials on cultural diversity, but again, awareness we have found is the first key step for getting people to improve their scores. This was an example of an African-American male OBGYN doctor, a very high-performing doctor. The only group that this doctor had fall out was meeting white women for the first time. Now, you don't want to stereotype. Not every white woman that met this doctor for the first time had a problem seeing him, but you can see that in the year 2006, enough did that it made quite a difference in his score. By being aware of that potential bias and spending extra time with that group of patients, you can see what happened to his scores over the next 2 years with that group of white women, to where the scores with meeting white women for the first time was pretty close to his return visit score. Now, I don't want to say that doctors are going to get this every year, but definitely by being aware, you'll certainly improve your scores overall. So this program started, it's grassroots, it started with my own scores. We've now reached over 6,000 physicians, and anybody, and also includes mid-levels such as midwives, nurse practitioners, optometrists. Anybody who sees a patient gets a survey. And this program has moved to almost every facility in Northern California. And this was an example of the increase in 1 year at our San Jose facility. You can see that their occupational health emergency department, OB, has significant gains in their scores over the next year. And in our facility, and this is something I'm proud of, is that 5 years ago, or in 2005, not one of our race and ethnic groups scored over 80% in satisfaction, and we had a 13-point gap between our white patient population and our Chinese patient population. Over the next several years, we've moved that score. Every group is now over 80%, and we've closed our gap to 4 points. And our hope is that we want to close the gap to 0. So, in conclusion, I think that it's amazing to me how many facilities don't collect data, or if they do collect data, they don't really look at it. I think data collection based on demographics is actually crucial for the future, especially as we start looking at more pay-for-performance metrics coming either at the facility level or your organizational level or from the government. I think when you break it down using analytics, it's a very effective approach for improvement at the physician level, the department, facility. I think when you just rely on overall score evaluation, you can have unintended consequences. I think that there's no limit to the complexity. You could be asking, questions around sexual orientation, people with disabilities. Certainly, I think we have room to add more race and ethnic categories to our scores. It really has no limit to the potential of the complexity. And the other thing is, I think many people are familiar with implicit bias testing, which I think is a valuable tool. But when you're actually able to use analytics, I think we now have the ability to actually help a physician identify potential unconscious bias either in themselves and or the patient. So with that, I just think that one of the things I've realized is that when working with hundreds of physicians around the region, as I've come to realize how unique every physician is, and based on their age, their gender, their race and ethnicity, their language skills, they will all attract different patient populations. They'll all have different variations in their scores. And by using a sophisticated database, you really can help them improve their scores and be better doctors. So I think for that, we'll take any questions. Oh, boy.
David, we have a couple questions that are coming up now. The first one is, are you able to analyze the patient satisfaction data on the basis of preferred spoken language?
Yes, right now we can do it on English, Chinese, and Spanish. And
I don't know if you can see that. Go ahead.
Educational bias. We don't collect educational scores on our outpatient setting, but we do with our HCAPs. And what we found is that there's an amazing amount of differentiation by educational level. And I'll give you an example. We happen to have a very old hospital here in Hayward. It was built in '62. It's actually going to be replaced by a brand new hospital in about 2 years. When I looked at the service scores for our women who delivered at the hospital based on educational level, the satisfaction score for high school grads was 70%, but our satisfaction scores for college-educated women was only 30%. And the biggest reason being is that they wanted private rooms, they wanted quiet. And so when we moved to a thing of not having shared rooms, we actually started to move our scores up with our educated, college-educated level women. And the other thing that impacted our scores is not only were the college-educated women much less likely to mark as high, but they also were 80% of the population. Unlike when we looked at our medical and surgical line, they tended to be more high school grads than college grads. How far-reaching are the analytics? We do age, we do gender, race, ethnicity, language. That's pretty much where we're at now. I think the key thing, though, is that what we do is we can take it very broad or very narrow. So it's not just how well do you do with Latino patients, but how well do you do with Latino women aged 18 to 34. So it starts to get very sophisticated. The tool we use is the survey that we had already been using since 1992. We didn't create a new survey. We just used the existing survey and started creating more databases. As far as the language groups, English-speaking patients scored the highest, Spanish-speaking the second highest, Asians, Chinese were the third highest. And it's interesting, though, when you go into the HCAP scores, the hospital setting, the Spanish-speaking patients were the highest score. The Latino patients were the highest scoring. So the thing about the gaps on language is one of the things we've done a lot of work here in our facility is really developing a strong interpreter service. It's really critical. We developed a remote video interpreting program, and for doctors to use interpreters, we found it had to be very quick and easy. So a physician is able to have a screen rolled into the exam room, dial KPI in the Kaiser Permanente interpreter network, and in 15 seconds you had a live interpreter on the screen. And this is very important for our ASL population as well, to have a high-def screen so you really have clarity around signing. And what we found is that the doctors, first of all, it's very quick to get an interpreter. Second of all, it didn't add to the length of the stay for the patient. Question is, once a bias is identified, what kind of programs do you have? What was amazing to me was the first step was awareness. It was amazing to me. I would ask physicians looking at the scores who they thought they had biases with and who they didn't. It was amazing how usually they were wrong. The groups they thought didn't like them may have scored them high, and the groups they thought liked them may have been just the opposite. Once the physician is aware that a certain group marks them low, it's amazing how you come back a year later, and for the most of the doctors, their scores go up. And when you ask them what they did, they say, I didn't do anything, and yet they did something because their scores went up. So we think that awareness is the first major step. But it could be a multitude of things that you have to bring in to help them move their scores. It could be cultural materials. It might be using interpreter services, more translated materials. You have to kind of do detective work to kind of figure out what they need. One of the interesting doctors I worked with was a Mandarin-speaking physician in San Francisco, and her only low score was with Chinese patients. And what the problem turned out to be was they were Cantonese speaking in San Francisco and not Mandarin speaking. So she was running into bias because of her speaking Mandarin. Well, the database is regional. So we have, we're collecting 1.5 million surveys a year, so we actually have a very large database, and we're able to break this down. I don't know if that answers the question. We do not check the socioeconomic status of the patients. I wish we did. I think it would be very revealing to have that kind of information, just like it would be for educational levels. If a family member accompanies the patient to an appointment, does the family member get a survey? No. Except in pediatrics. In pediatrics, the survey goes to the parents.
I think we, does anyone else have any other questions they want to send through the chat function? Thank you. This has been great to set up so many questions. There's just a clarifying question there on does regional equate to California?
No, it's interesting. Southern California, Kaiser does not have use this tool. This is only Northern California.
Great. Well, if there's any other questions, let's shoot them in now.
Yeah, we got.
Otherwise, David, thank you. Do you have anything else coming in? Well, thank you all. Thank you, Dr. Newhouse, so much for your time. And
yeah, I'll put my email address on the program that can go out. And if anybody has any questions, feel free to email me separately. I'd be glad to answer any questions. I think, you know, as you think about this, it had a lot thrown at you in a very short period of time here. It's kind of hard when you do a webinar compared to getting up in front of speaking people, because you kind of go through the program much quicker. But I think as you think about the databases you've seen, if you have more questions about them, I'd be certainly glad to answer them.
Great. And just as a reminder, we will be posting the slides on the California Improvement website, network website, in about a week. So that will have the slides as well as the audio of the session and the Q&A recording. So, and just as a reminder, next month the webinar will be on May 23rd at usual time, 12:30. The topic will be patient-centered medical homes. So keep a lookout for the announcement on that. And with that, I thank you all for joining, and Dr. Newhouse, thank you very much for your time.
All right, thank you.